1.
Hello, good morning everybody, and welcome to the Centre for Ageing Research Maintaining Health in Older Age Town and Gown event. This is our first online event, as I'm sure you're aware, and although we've had to do this, it also presents us with some interesting ways to do things. So hopefully you'll enjoy our varied programme today. So what I'm going to do now is just introduce the programme a little bit to you, because obviously it's different for everybody, the way we're doing things. So I'm welcoming you and explaining the programme now, and then we have a talk from Asan Akpan in a moment, and then some further talks. And what we'll do is we'll have a short time for discussion straight after Asan's talk, but then the next four shorter talks, we'll save the questions to the end. You can't actually ask a question orally, but you can type your question in the chat that hopefully you can see on the right hand side, and then I'll be able to see those and I'll be able to read the questions out to the speakers. The advantage to this method is you don't have to wait to the end of the talk to put your questions in. You can ask your questions as you think about them as we go through. Anthony, could you move on to the next slide?
Yep, the slide is actually on your machine. So if you just advance the slide on your machine, it should advance.
Yeah, that's not happening.
OK, click inside it and then advance with your keyboard.
Yeah, OK, thank you. Right, so after that, so we're having the morning session will be about 2 hours. And then we've got quite a long lunch break until 5 to 1, so a 2-hour break in the middle. But what we've done, normally if you've been to a town and gown event before, you'll know that at lunchtime we have an exhibition with some posters, often from students talking about their own research. And we've got that today. So each poster is an individual meeting. So Louise has already sent you a copy of this programme. And where there is the blue Meet Winnie or Meet Elizabeth words, if you just click on those, that'll take you into a Teams meeting where you can see the posters and talk to the author of the posters, and hopefully see some of the other people who are looking at the same poster as you, just like if we were in a normal exhibition hall. So as well as the posters, we've got some other elements to our exhibition. You can meet the continuing learning group. You can talk to Kate Slade about her research study on hearing loss. You can learn about the Centre for Ageing Research panel in terms of, how can I get involved in the research at Lancaster University. And then you can also talk to people who run postgraduate courses on ageing and dementia if you're interested in that. So it should work a little bit like a normal exhibition, and you just go from room to room or Teams meeting to Teams meeting just by clicking on the blue words. And then in the afternoon, Trevor Crawford, who's the Deputy Director of the Centre for Ageing, is going to chair, and we have some more really interesting talks to you. We've got a bit of a focus on COVID, as you might expect, and then a range of topics that show the range of interventions and the range of work that we do on maintaining well-being, not just focused on the medical side, but focused on other sides as well. And then we'll hopefully finish around about 2:30. OK, so I hope you really enjoy the day, and if I could hand over to Asan now, who's going to present our first talk.
Asan, if you just unmute your microphone.
Okay. Hello, everybody. Good morning. My name is Asan Akpan, and I'm a clinician who specializes in the care of older people based in Liverpool. But before I go into my main presentation, I'll just give you a little bit about my interests and background so that you know where I'm coming from. I do have an interest in population health, especially looking at the determinants of well-being and health. And especially in the area where we live and work in, there are lots of differences in life expectancy and in affluence. And that interests me on how people respond to healthcare interventions. So I do get involved in discussions and also research projects with colleagues who have an interest in that area. In terms of aging research specifically, I do have a broad area of interest. I am interested in frailty, care homes. I've done work with biomechanics, looking at footwear, gait. I just tend to have a broad area of interest. If it interests me and people really want me to join in their group, I certainly do. But I'm also a learner. And one thing I learned very early on in my journey in academic medicine was that I wasn't as well prepared as I could have been when I was training. And one way to sort this out, I thought, would be to actually enroll in a PhD program, which I'm pleased to say I'm doing at Lancaster University. And it's going well. That's what I can say. It's going well, and I'm learning a lot. So that's my background. And today, when I'll be talking, that might come across. So one of the things that I've always been interested in for many, many years now is what matters to the people that we look after in healthcare, what matters to the people that we're doing research about. If you think about it, if you want to do something that's very meaningful, you need to get all the stakeholders on board. And traditionally in healthcare, many, many years ago, we never used to think about the people we looked after as key stakeholders. It sounds strange now, and a lot of decisions were made by providers or people doing the research, but we never actually truly, authentically involved those who actually had the conditions that we were interested in. So of course that has changed a lot now. And a few years ago, the James Lind Alliance convened a group of older people with researchers and other interested stakeholders in Newcastle, and they came up with key issues that were of interest to older people, and I'll be sharing that with you. And when you see it, probably you will not be surprised. So older people stated that they suffered with problems in the following areas. So we know we're all going to get old, so these are the things that some of us will have. So, look forward to old age, because as you can see, we're going to have challenges with mobility problems. Yeah, not a surprise there. Problems with hearing, with our eyesight, problems with our memory, feeling tired, exhausted, breathless, pain, stumbling, tripping, falling, dizziness, problems with eating and drinking. So I think we all have relatives who are old, or we have friends who are old, and a lot of this will not be a surprise. But it's good to see older people actually stating, how significant this can be in their lives. So while there are lots of issues there, some are more prominent. And this is important because as we want to do research, it's important that we don't neglect certain areas, especially if it's of a major concern to older people. And this is why it's important to have them as key stakeholders when we are trying to design or think about any research that we want to do, because this then comes into the fore and guides us so that whatever we do is very meaningful. A couple of years ago, so the James Lind Alliance, the slide I just showed you, that was more of a sort of a national picture. A few years ago, I was fortunate to be part of a group of international stakeholders. So this was more of a global effort to try and see what was important to older people when they encountered healthcare providers, what was important. And again, if you look at that that picture slide, a lot of the things I mentioned on the previous slides are there, and that's not surprising. So older people were concerned about the number of drugs they were taking, so polypharmacy. So while we don't have an immediate solution, we know that that's a concern, and that's not a surprise. The more tablets you take, the more side effects you're going to have, and that may actually then start causing harm. Again, you can see that lots of people were having problems with falls. They were concerned with pain. There was concern about isolation and carer burden. So a lot of the things that were mentioned in a previous meeting at a national level is reflected globally as a concern that older people have.
Hassan, before you continue, sorry, your slides aren't advancing at the moment. It might be that you're sharing the wrong window.
Yes.
If you go into the edit window, which has the slides visible on the left-hand side, if you're unable to actually show the slideshow itself, you can advance using those slides, which might be more helpful.
Okay.
So if you click each of those slides, the audience will be able to see those.
Can you see them now?
I can see the first slide, but you might need to select one of the others to advance through them.
Okay. I don't know if you want to do it for me, because I don't seem to be able to do that then.
Okay, just one moment. Okay, so I'm sharing it now. And what slide were you on, Hassan? Hassan, I need you to unmute your microphone again. Yeah, which slide?
Fourth slide, please.
Number 4. Okay,
Yes.
so
Okay.
so number 4 is showing now. So please continue to that.
Thank you. So I'm sorry, I was told I was not advancing my slides, or you were not seeing them. So this slide is what the James Lind Alliance convened a group of older people, and these were the issues that were of importance to them, which I had mentioned earlier. So you can see there at a glance the challenges that we're all going to have when we get old, and that our older people have at the moment. Okay, next slide, please. When we looked at this globally with a group of stakeholders from almost all the continents in the world, again, the themes that emerged were very similar. Next slide, please. And locally in Liverpool, a 5th-year medical student did some work with me looking at older people with frailty, so people who are mainly 80 and above, to see what was of value, what they really were thinking about, what they were worrying about when they encountered healthcare professionals. And again, there were some themes that were similar to what we'd picked up. Next slide, please. So what I've done here with this slide is, on the left-hand side, I've put down what older people identified as things that were of importance to them, what they felt were the most concern to them, what was challenging in their lives. And on the other side, I've put down what people who provide healthcare or who do research have identified as sort of their research interest or what they are working on. And there isn't a lot of dissimilarity. Things can align. So this is where when we want to do the research, if we can get older people to be in front from the very beginning, I think our outcomes, what we do, can be more nuanced, can be more meaningful and relevant. And I'll use a good example. So more of a clinical example. When we're designing drug trials, a lot of the people who are in those drug trials are less than 70 years of age. But those drugs, when they then come out, are consumed significantly by people who are above that age. Yes, they are consumed by people above the age of 50, but a lot of those medications, and a lot of them, are consumed by people above that age who were not in those trials. And then, not surprisingly, we have a lot of problems because those issues that could have been identified if they had been put in those trials were not. And it's only when they start taking those medications that we start having problems. So that's a very good example. And everyone is beginning to realize that this is an issue and we should not exclude older people. Rather, we should develop sound methodologies to address the reason why we're excluding them in the first place so that they can be included in those trials, since they are going to be having these medications. And that can apply to everything else. I think I am coming to the end and I don't want to take up too much time. And what I would like is to leave more time for questions and answers. So I'll sort of end at this point. Thank you very much.
Thanks, Hassan. There's just a few comments in the chat about people who couldn't quite read the slides because it wasn't on full screen. But I just wondered if you could perhaps just start the discussion by just reading out. I think slide 7 was particularly useful to think about. If you could just read out the 2 columns and how they match up, that would be really helpful, I think, for people who couldn't quite see the slides.
Yes. Okay. So in slide 7, what I've tried to do is bring together what matters to older people with what researchers and healthcare providers are interested in. So on the left-hand side, we have mobility, fatigue, pain, and dexterity as the key issues that was of key concern to older people. The other challenges that they had were hearing, vision, problems with their bowels, problems with their memory, and bladder problems. On the right-hand side, things that researchers and healthcare providers were interested in and were working on included exercise therapy, falls, social isolation, psychological well-being, independent living, carer well-being, integrated care, prevention of multiple chronic conditions, frailty, and comprehensive geriatric assessment. And what I was saying is that there is a lot of alignment between this, but when we get down to specific projects, it's very important that we have all the stakeholders. So you have older people on your design group, you have the researcher, and you have people who provide the care, whether they are social care professionals or clinicians, doesn't matter. Just you have a much more meaningful research design, and your research output will be so much more meaningful and applicable if you've got all those stakeholders right from the very beginning. And yes, it is not easy, it is challenging, but as researchers, I think it is for us to develop the right sound methodology to try and reduce the number of people we exclude from trials. Because when you do provide care to people, you're not going to say, well, sorry, you were not in the trial, so I'm not going to give you any care. So knowing that we do have to provide care to people, we should aim to be reducing people we exclude from trials and developing methodologies to address that.
Thank you. Thanks. That's really, I think that's really important. And I think the message has kind of got through to researchers and to the medical profession. I just wondered if people in the audience had any other sort of health issues that they think we should be doing research on that haven't come up on your slides. I thought it might be useful to start the discussion to see what else people thought researchers, and particularly medical researchers, should be doing some research on. So if you have some suggestions, just type it into the slide, into the Q&A. Does anybody else want to come in?
I'm sure this will come up later, but one of the things we found with the COVID, for example, is while we did something based on evidence, which was to restrict frail older people to stay in their home, what has become evident is the psychological and physical harm from deconditioning and loss of contact with older people. So there is an example where we followed a pure clinical medical model for the right reasons. But if we had, or now that we are engaging with older people and we can see what has happened, I'm hoping that going forward, we will have a smarter way of balancing those risks and benefits and doing something to mitigate the psychological and functional decline that can occur. So there is an example of something where trying to involve everybody to provide better care.
Yeah, I think that's important. That'll come up later this afternoon in our COVID session. Somebody else has asked for the tags for the social media posts. I don't know if Louise or Theo could type those in. That would be useful. So that's the Centre for Ageing Twitter is the main one there. So we haven't got any other questions at the moment, so do keep putting the questions in. We can always come back to Asan later if you add a question that's appropriate for Asan to answer. So thank you very much, Asan. If we were all in a room together, we'd do a clap now. But we can't necessarily do that on this kind of medium. Can we move on to the next talk now? So it's Christine. Christine Milligan is going to be talking to us next, and Christine's going to be talking to us about wilderness and nature adventure sport in later life, understanding the mechanisms for well-being. So thank you, Christine.
Hi, Carol, can you hear me?
Yes.
Great. Well, thanks very much for that. Yeah, so my talk is shifting away a little bit from the concepts of frailty and ill health that Asan was talking about, to looking at the sorts of activities that older people can engage in later life. And one of the things we were particularly interested in exploring was issues around wilderness and well-being through what is commonly termed as nature activity. And what we mean by nature activity are the activities that involve a voluntary engagement in novel, uncertain and emotionally intense recreational activity. So typically those sorts of things might be things like fell running or mountaineering or windsurfing and those sorts of activities. And we'll talk a little bit more about those as we go through. Anthony, I'm also having problems advancing the slides.
Christine, if you just click inside your slide and then don't use your keyboard, don't use your mouse.
Yeah. Oh, okay. Lovely. Thanks. Okay, so why are we interested in this? In part, it was because there has been quite a lot of recent research that has acknowledged that physical activities in natural environments, including the associated emotional components of those physical engagements, can make a real positive contribution to health and well-being. There's also been growing inclusion of engagement with the natural environment within mental health policies, and we've seen that through things like a focus on social prescribing, particularly in the UK. And there's also been an increased interest, both nationally and internationally, in wilderness-based therapies. But one of the things I think we've noticed as we were looking at this work and becoming interested in the work is there is a lot of evidence to say, yes, it does improve well-being, but what there is less evidence about is, well, why does it and how does that work? And so these are the sorts of questions that we've been interested in trying to look at and beginning a piece of pilot work to think about understanding the mechanisms that actually contribute to this. So as I said, this was an exploratory in-depth pilot study involving 12 people to explore, firstly, why they engage with wilderness in these sorts of activities in the first place. What are the impacts and how have they evolved over time? How does engaging with the wilderness impact on people's mental and physical well-being and on their sense of self? In other words, what are the mechanisms through which this well-being activity is realised? What kinds of nature activities work and for whom? So that's in terms of where it takes place, the location, the activities themselves, whether it's a social or an individual activities and so forth, and what sustains that engagement, what makes people carry on doing that, those activities. So in talking to older people, so one of the first things we were asking is, how do they define wilderness? What does wilderness mean to them in this day and age? And as many of them rightly pointed out, there is no real wilderness left in the UK, perhaps parts of the Scottish Highlands, but most of it has been managed in some shape or form. So when they think about wilderness, what they're talking about is those much less manicured, unmanaged landscapes, often mountainous, can be seascapes, but importantly, there's no or limited human impact. Many of them described it as backcountry, country that's away from civilization and the modern conveniences and a long way from help. And they talked particularly about, for them, it can often be areas where, for example, their mobile phone signals won't work, so that they know they're away from that kind of what we normally deem to be a kind of civilization. They talked about important characteristics of wilderness, areas that are quiet, have a natural beauty, they're outside and remote, devoid of people, and particularly habitat for wildlife. But for them, wilderness was also a feeling or an emotion. So engaging with wilderness gave a feeling of a sense of wonder, fear, terror, excitement, a sense of challenge, a sense of aloneness. But importantly, for them, in connecting to that idea of activity and engaging in wilderness activity, it needed to be linked to adventure and risk and fun. So in thinking about what triggered people to engage with these nature activities in the first place, we're talking about roots into that. Often it was formative childhood experiences, so that could be youth engagement experiences, that might be with parents taking them to these areas. It might be with community groups, so scouts, guides, schools, colleges, universities and so on, that first encourage them to engage with those. It might be work or voluntary related, so people talked about being in the armed forces and engaging with wilderness through armed force activities, being involved in things like the Duke of Edinburgh scheme and so on. It might be about engaging with it because that's something that their partners have been interested in, or their neighbours have encouraged them to engage with, or friends and so on. And for some, it's also been about critical moments in the life course. So moving home, retiring, changing life, getting a health scare or an awakening that's made them think about the need to engage in other sorts of activities in other sorts of places. So having looked at this, I want to just read you through a vignette that sort of characterises the sorts of experiences that our participants were engaged in. So here we've got somebody that I've called Bob, and we've got a lovely picture of Bob here. So Bob moved to the Lake District 30 years ago because he found his previous place of residence, a smallish city, was becoming too urban for him. The nature activities that he was involved in included mountain biking, cycling, mountaineering, skiing and windsurfing, although he hasn't done the latter, windsurfing, for many years. While windsurfing was his first love, he changed to mountain biking some years ago as he got fed up with having to wait for the right conditions to windsurf. He said, as he got more experienced in his windsurfing, only certain conditions would do for him. Mountain biking, he said, can be done anytime in wet conditions or dry conditions, and the wet conditions only enhance the challenge for him. For him, he loves that challenge, the adrenaline rush he gets from nature activities. He maintains that specific types of nature activities, such as mountain biking, windsurfing and mountaineering, were good for his mental health, especially when experiencing a period of anxiety and depression. They required both mental and physical engagement in ways that left no room for him to focus on his anxiety and depression. And he compared this to walking and road biking in these same sorts of areas, which, while having their own well-being benefits, didn't require the same combination of mental concentration and physical engagement. So rather, he noted that these types of activities allowed him the mental headspace to work through what he called knotty issues that he was unable to resolve in the office. And he said he would have wouldn't have gained those same benefits from indoor activity, where the body becomes physically exhausted, but it didn't have that same stimulation. Similarly, engaging outside in activities like painting or less active pursuits would not have had that same impact for him. It was about the dual physical mental capacities would not be engaged in the same way. So I think what Bob's vignette is highlighting is how nature activities have a positive impact on his well-being, but those different types of activities do so through different mechanisms. On the one hand, nature activities that require skill and intense concentration, such as mountaineering and windsurfing, act positively through filling the mind, allowing no room for him to focus on his mental health issues. Whether or not this had a long-lasting effect is something we need to follow through. But on the other hand, nature activities like walking or road cycling through wilderness allowed for strenuous physical work out of the body, but at the same time it was freeing up the mind to work through those knotty issues that had been unable to resolve in his workplace or at home. Importantly, place, wilderness, and the activity itself were key mechanisms that were seen as critical to how the individual dual physical mental well-being was positively impacted over passive engagements were key. So there's a clear physical and emotional relationship here between the individual, their activities and wilderness. So just talking about those, some of the older people you're engaging with talk about the activities as enhancing and enabling in later life. And just a few quotes here about, even now I like climbing with friends my own age because I can look at challenges that I have physically and come up with solutions for someone else who is probably in the same boat as me. So it's about both that physical and emotional engagement. I think a lot of the people that stick with it, they're getting some mental fillip, a kick that's some positive impact on their mental health. But it's also about recognising and dealing with non-completion. You spend a lot of time analysing, well, maybe I haven't eaten properly, I haven't trained enough, instead of just accepting you can't do everything. Well, you can't, it's dealing with that failure. Well, I don't think you could call it failure, but you've got to deal with the fact that you haven't completed something, that you've gone out to do that. And coping with the challenges of the aging body. So I do go climbing, but I'll do the easy stuff now because I haven't got the strength to do the hard stuff. Plus, I've lost my head for confidence at height. I find it physically harder to face it. And I've been doing it for a long time. So as you get older, you're relying less on your physical ability and more on technique. So there's something here about people still engaging with those activities as they get older, but finding ways to cope with them in slightly different ways. About a preference for nature activities that can change over the life course. So people talked about changing and doing wild swimming, and one saying, I notice a lot of older women get into swimming. It seems to suit our bodies quite well and much less damaging. But importantly, they talk about that in wild places. So this is not going into a swimming pool. This is about engaging in lochs and lakes and sea swimming. It's nice to think about that challenge. What I'm used to what I'm going to do next and how I keep up that level while still recognizing that some of these youngsters come past me on their bikes when I'm out riding. It's no use me getting upset about that. I can accept that because they're younger, they're fitter, and I wouldn't necessarily say healthier because I'd like to think I'm healthy, but it's recognizing the age difference, isn't it? And what comes with aging. So it's about recognizing that you're not in it to win, but in it to engage. So finally, this has left us with the original question about, you know, trying to understand. We know that nature activity in wilderness environments has a positive impact, but we still don't have the answer. Why? What are the mechanisms? And this is us beginning to think through what are those mechanisms. People often refer to the dopamine effect, in other words, some sort of biochemical reaction. But while that might in part explain it, I think we feel it's far from the whole, and it's a much more about mechanisms and rather mechanism. For example, we discussed here how different types of activities can impact on well-being in different ways. How routes into these activities can be important, and when and what activities people engage with, and how these activities change over time. And as a result, we've come up with this kind of a preliminary model that we're beginning to think through from this pilot study that we think underlie the well-being impacts. And the model demonstrates it's not one single mechanism. Rather, we need to think about a range of mechanisms, often operating across a series of spectra, from active to passive, safety to risk. For some people, it's engaging with that element of risk in a managed way that can be important, whether it's being alone, doing something like mountain biking, or whether it's doing with other people and that social activity that is important. But important, these are all connected to place. So where that activity takes place in these sort of wilderness places is instrumental for well-being. So, as I say, this is a initial model that we begin to draw out. You can see the kind of spectra that we are trying to think through, and how engaging with these activities can take you from the problems and conflicts and worries that might be part of your life to a much calmer place by engaging these activities. And I'll finish there. Thank you.
Thanks, Christine. Really interesting. So there's some questions already popping up in the Q&A, but we'll leave them for the discussion time after the next few talks. So the next talk is Theo Bampouras. So his title is "If You Don't Use It, You Lose It," and he's going to talk about the secret benefits of physical activity. Theo, are you ready? Are you there?
Well, I am as ready as I can be, yes. Thank you very much. I hope everybody can hear me, and I hope everybody will be able to see my slides once I share first. And you should be able to see the slide now, right?
Yes, that's fine. I can
Perfect.
see it.
Brilliant. Okay.
That's brilliant.
So this is as Carol already mentioned, this is the main topic of my talk. But before I reveal the secret, I've got a little experiment for us. So I will put here on the Q&A, if that's okay, the link, and I would like people to go onto this link and use this code. And we'll do a little quick experiment. I'm asking you to think, I'm saying single word on the question, but you'll see I'm asking for 3 words that you think of when you hear physical activity. So if you go on the Q&A, you can click on the link and it will take you directly, and you can enter the code there, or you can use it on your phone, or you can use it in any media that you want. And hopefully that will give us some nice results, which I will show you once we start getting through. So you can go on the link and use the code that you see on your screen. You should be able to type in the words and submit. Excellent. Okay. So I'm not showing you exactly what's coming up because then I don't want you to be biased with what you put down. Once we don't have any more, then I'll share the screen briefly with you, and we can see what we have. Okay. Okay. So while people are still completing, let me just show you. Yes. Let me just show you the screen, and you should all now be seeing the results as they're becoming live, right?
Yep, we can see that there.
Perfect. So what this shows us is that the bigger the word, the more people have stated it, and the smaller the word, less people have stated. And you can see in the middle, enjoyable seems to be the focal point. Hard work seems to be another one. Fun seems to be something else. Health, sweaty, pleasurable are also words that are being thrown in there, which is a very nice overview for a number of things. One, to try and indicate the sort of vast range of things that physical activity mean to people. But also, I'm very, very pleased to see, oh, pain just came up there. I was just about to say, I'm very, very pleased to see enjoyable is the main word. So as people keep completing this, I'll go back to the presentation, and we can, yes, I want to share again. Okay, so I'll come back to this point at the end, but I like that variability of responses. Two things really that I want to focus on today. One is about maintaining health in everyday life as our topic of these talks through physical activity, and also about rehabilitation, which is maybe something we don't think as much. But before we talk, there you go. Before we talk about the everyday life, I want to try and explain. We talk about physical activity and important health, and whether people want to do it or not is a different matter, I guess. But why I think it's important, and what we see here is the horizontal line is age. So from the point of where we're born, as we grow older, going to the right-hand side, and then the vertical line, the functional capacity, is our ability to do things independently. And what you see there are two lines, a blue line and an orange line, and they go up in early life. So from getting born, we become stronger, we start walking, we start being able to get dressed, comb our hair, go out, eat, all of those things. And then at some point in adult life, it starts decreasing. And you see there are two distinct trajectories. The blue line is quite higher up, and the orange line is quite lower down. And that gives us the range of functional outcomes, the range of functional ability within a population. On its own, it's not overly important. It becomes more important if we are towards the orange line, because we have what we call disability threshold. And disability threshold, as you can see there, is the threshold below which we're not able to function independently. So there is a point at which we're not able to be independent anymore. And for me, that's the issue. That's the issue we're called to resolve. How can we remain independent and enjoy life? And that seems a little bit sort of doom and gloom, I suppose. But the message here is that, is this actionable? Can we not be on the orange line? And the answer is yes. The answer is yes, and we can not be on the orange line. And also, what is even more important is that we can do it with a number of things, with a number of activities, we can do that. Some of these, you may read them and roll your eyes, and I can hear some people's eyes rolling already. That's absolutely fine. There are other activities that we might not immediately think about. So walking the dog, shopping, If somebody wants to do resistance training, that's for them, they can do that. Yoga, that's for them, they can do that. Walking the dog, that's for them, they can do that. So you can be as colorful as you want. You can pick the activity that you want. Ultimately, as we will see later on, the idea is that we find something that we enjoy doing and we're able to do. There is this perception that I think goes around from talking to people that I work with about physical activity, and that's why the range of words that came out in the word cloud was very nice to see. There were also things around sweat, hard work. I don't want to look big like people in the gym, but physical activity is not about looking like Arnie. Physical activity is not about, you know, running for 3 hours. If you want to do that, that is absolutely fine. If you don't want to do that, that is absolutely fine. So you can do any of those activities. You can do passive weights, as the lady on the first picture. We did a study a few years back about carrying shopping bags, and it's a nice activity because it's something you have to do, get you out of the house, but also means that you load your limbs by carrying shopping home. So there are a number of activities that we can do for our everyday life. I will not go too much into the strength because I know Jen is coming after me and we'll talk about sarcopenia. She will tell you all about muscle mass and what that does. What I want to go now into is the second part of the talk on the rehabilitation or rehabilitation, and something that we forget potentially is how important being physically fit is in a situation where somebody has a disease or we're coming out of an operation. And we have plenty of evidence again and again showing us that people that were physically active are better in recovery than people that are not physically active. What is even more important is the fact that people that were not even previously physically active, if they start becoming active, that will also help them in the recovery. And what I want to present here for the next few minutes, and I'm hoping I will not be talking for too long, so we can have a discussion with questions. Is a case study of a project that started a few years ago and continues to this day. So we place those, if you look at the top image there, that picture of this gentleman cycling, we put those bikes at the edge of the bed and we ask people to cycle if they wanted, for however long they wanted, at whatever intensity they wanted. It was not prescribed, it was not a program given to them. You have to come in, you have to cycle for X amount of days, X amount of times, and all the rest of it. To give you context, those guys were coming into the hospital for dialysis every other day. So they were at the hospital 3 or 4 times a week. Dialysis takes about 4 hours. So for 4 hours, you're lying in bed, not really doing much. We did some testing before and after 6 weeks, and the testing can be seen at the little wonderful drawing that I have done with circles and lines at the bottom. So we had them sat in a chair, attach the device at their ankle, attach that device at the back of the chair, and we asked them to try and kick out. That device would not give, so we're able to measure their strength. And what we found was actually their strength increased between baseline and 6 weeks after. And every single person, as you can see on the chart on the far right, has increased. What we also did was we took a control measurement from their hand grip strength as a control to see if their strength goes up. And actually, the hand grip strength did not go up. So cycling worked. Even something as simple as cycling horizontally on the bed worked. Now, that's great news from a research perspective. We found results. Yes, that's all fantastic. For those guys, what it meant was the fact that some of them lost some weight, so it became easier to walk around. And for renal patients, it's also important because if they're over a certain body mass, they can't go on the transplant list. What it meant was people were able to go with their partner to Asda, to Sainsbury's, to Tesco. I don't try to promote any brand, by the way. It's just a supermarket. They were able to go and shop with their partners. They didn't have to wait in the car. They were able to go out in the garden and play with their grandchildren. That's quality of life. You know, that is quality of life. And that's a big advantage of them being able to do something like this, even during their dialysis. Our most recent project is now looking into frail, and Hassan was talking about frail earlier on. Christine moved away. I'm kind of bringing it back again. Talking about frail individuals and chronic kidney disease patients, and how exercise can be done at home, and they can swap potentially from being frail to being pre-frail, or from frail to being robust. Carol, am I going over time? Sorry, I did not even look at the time. Okay. I can't hear you, but I'll pretend that you said no, and I've got 2 more minutes.
Yeah, 1 minute.
Oh, okay. So, in conclusion, you'd be pleased to know, for me, what is important to remember is that physical activity is something that we should enjoy doing it. It's something that we find something that we can do to enjoy, and be able to go from nothing to something, and from something to more. One thing does not fit everybody, but there are a lot of things that we can do that somebody will find something they enjoy doing. And that's my minute. Thank you very much for listening. I'm happy to take any questions.
Thanks, thanks, Theo. So there's some questions appearing in the Q&A, and we'll save them until after the next couple of speakers.
Okay.
So thank you very much, and again a clap, a virtual clap. So the next talk is from Jen Logue, who's going to talk about weight loss in later life. Is it a good thing or not? So thanks, Jen, if you're ready.
Hopefully I'm ready.
Yeah.
Has that shown?
Yeah, there you are. So if you could put that on the, that's on the slideshow, that's great.
Is that all working? Great. Okay, thank you very much. So as Carol said, my name is Jennifer Logue. I am an academic in Lancaster University, and I'm also a consultant in metabolic medicine working at Royal Lancaster Infirmary. And I'm not going to put my camera on this morning because I had surgery on my mouth yesterday and I look quite a state. So do excuse me if I also slur while I'm speaking. I've not had a drink this morning. So we're going to talk today about intentional weight loss in later life and if it is a good thing. And you might be sitting there thinking, well, what are you talking about? Is it a good thing? Because all we hear about just now is why it would be a good thing to lose weight. So especially just now, we're hearing that people with obesity are more likely to get severe complications if they get the coronavirus. We've got Public Health England producing apps and giving discounts for Weight Watchers and Slimming World and other clubs to help people lose weight at this time. We've had a big push in the last couple of years on type 2 diabetes, both in terms of prevention with a national programme for that, and also more recently diabetes remission. That's helping people that have got type 2 diabetes get their blood sugar below the level that they would be considered having type 2 diabetes, and that's happening through very low calorie diets, and again that's going to be rolled out nationally. And then we've also had campaigns like this one from Cancer Research UK, focusing that obesity is the biggest cause of cancer after smoking. But is weight loss good for you, especially when you're older? Well, why would that even be a question? Of course it is. It surely must be better to be lighter than it is to be heavier. But actually, when we start thinking about older adults, that story gets a bit muddled, and this is the reason why. Now, I've picked this one study from France to show you, just because actually it had a nice colourful graph that went with it, but this has been repeated lots of times. And what we have here is about 3,500 people from France over the age of 65, and they were followed up for 13 years. And then what they've done is they've taken them based on what their body mass index is. So these black and orange lines are the people that are lighter, and then up to the light blue line, which is the heaviest group, and that's people that have got a body mass index above 30, so therefore would be categorised as having obesity. And what this shows us is that actually the people that the survival decreases, so therefore they are dying more quickly, are actually the people in the lightest groups. And the people that are surviving most are the people in the heaviest groups. And this has concerned a lot of people. You know, is there something about being heavier when you're older that is actually protective? As my gran would always said, is it better to have a bit of meat on your bones at that time in order to help you deal with what life might throw at you. And it's worth thinking about actually why some people are thin. So if you could see me today, you would see that I am one of the lucky people who is naturally thin. Now, is that because of a healthy diet? Is it because I'm physically active, or lucky genetics, or a combination of all three? And those are things that we would associate probably with good health and good health outcomes. But there's other reasons that people might be thin. Smoking is one of those. So if you look at Hollywood actors, the vast majority of them smoke, and they do it because it keeps them very thin. Unfortunately, one reason it puts people off smoking is they know they will gain weight afterwards as their appetite comes back. Smoking is an appetite suppressant. Have they got chronic illness? Now, some chronic illnesses cause people to gain weight, sometimes through the medications or being unable to be physically active, but some chronic illnesses result in being thinner. And then what about fatal illness? So there comes a point in your life where if you meet a friend that you haven't seen for a while, and actually you've lost a couple of stones since you last saw them, that rather than congratulating you, they might start to be more concerned. And that's because we know that if someone's got cancer or severe heart failure, then actually they can lose a lot of weight, and that's clearly not a good thing. So that might be what's happening in this French study. In fact, those people that are lightest because they're unwell, or they're light because they're smokers, and therefore that's why they're dying sooner. But we've never actually done a study to show that if you lose weight, you live longer. And that's because it would take a huge study to do that, and it's quite hard to make people lose weight and for it to stay off. But even if we know that, don't know about it making you live longer, we do know that it helps improve your cholesterol, reduces your blood pressure, can help with pressure on joints if you've got osteoarthritis. And that's why we recommend it in general. But there is still a question mark over what we should recommend in older adults. And as Theo said, I'm going to talk a little bit here about a concept called sarcopenia. Now, if you take a 25-year-old and a 75-year-old that are both 70 kilograms, that's around 11 stone, then they are not the same. I probably don't need to tell anyone that they're not the same. They have very different composition that makes up that 70 kilograms. So someone who is older has less muscle and more fat. And when we talk about sarcopenia, that's an extreme example of this. And that's when it gets to the point that you've got decreased muscle strength, decreased muscle quantity and quality, and decreased physical performance because of that. And when an older adult loses weight, some of these things become very important. So this graph here is from a study of 30 older adults with obesity, and they were put on a low-calorie diet for 6 months. And the black lines are showing what happened to the group that were on the diet. So they lost just over about 10 kilograms. That's nearly 2 stone. So that was a really good result in terms of weight loss. I'd be very pleased if I saw that in my own clinical practice. And the second line shows that they did lose some fat, but they also lost about between 3 and 4 kilograms of fat-free mass, and that is muscle and bone that they lost. What they also did in this study, though, was they had a second group, and the second group had the diet, but they also did exercise, and that was mostly resistance training. They lost weight, pretty much around the same as the other group, but actually they lost more fat and a lot less muscle. So that starts to tell us that maybe there's something that we can do, particularly as an older adult when losing weight, to try and make sure that we're losing the weight from the places that we want to, whilst maintaining our muscle mass. But what should I do? And I don't mean me, I mean you. What should you do here? So far I've told you that being thin might kill you, that if you go on a diet, you might lose all your muscle, but really you just want to look nice for going to your niece's wedding. And that's actually what's motivating you to want to lose weight. And this is a big problem that we've got, in that what we look at in studies probably differs even from what I'm interested in when I'm doing my clinics, and is certainly quite different from what motivates individuals with obesity who want to lose weight, which tends to be for much more personal reasons around wanting to feel a certain way or be able to do a certain thing. So the next slide should hopefully help a bit with this. This is a study, again, done quite a number of years ago, back in 2011 now, and it's about just over 100 adults. They're over age 65 and they've all got obesity, so they've all got a body mass index above 100. And they were randomly assigned to 1 year of a low-calorie diet, 3 90-minute exercise classes a week. Now that's a lot. And these exercise classes, they were a mixture of different types of exercise. So they did some strength training, you know, mini weights, not pumping iron, but mini weights and stretchy bands. They did some aerobic exercises, things like Zumba and other aerobics. And they also worked on their flexibility and their balance with yoga type exercises and Tai Chi. And they did that 3 times a week. The third group actually also went on a diet and did the exercise, and the fourth group was the control arm. Now, the outcome that they looked at in this study was not how much weight people lost or how much muscle they had or what their cholesterol was, but instead it was a range of physical functions. And you're all lucky that you're not here in person, because I was going to get people to do this in person. So you've got a pass for that today. But this included walking for 50 feet, putting on and removing a coat, picking up a penny from the ground, standing up from a chair, lifting a book, climbing a flight of stairs, and performing a 360-degree turn. And they also looked at quality of life as well. And what I've shown here is the change in that physical function score over a year. And the bottom line there, that's almost flat, is the control group. They didn't have any change of this. And then you can see this graded increase up to a 20% improvement in that in the group that did diet and exercise. So to me, the answer of what you should do is, yes, lose weight if that's what you want to do, but also do the exercise as well. And that is something that actually we don't recommend necessarily for younger adults. We generally say go in with diet and then use exercise to help maintain your weight loss. But in older adults, you should really do a combination of diet and exercise. And that exercise needs to be a combination of aerobic and strength and flexibility and balancing type exercises to allow that. But we also need to think about a personalised approach, because there will be some of you sitting watching this going, well, actually, I have limited mobility. I can't do that. I can't do the physical activity. Or I have this chronic lung condition that means I can't do it. And we need to think about the individual, and I can't give that kind of information over a talk. But it's really about balancing up the risks and the benefits, and it will depend on what's going on with you. If you have type 2 diabetes, then generally the benefits of weight loss always trump any theoretical risks with it. Whereas if you have chronic lung disease or chronic heart disease with heart failure, then actually it might be the case that you would be better maintaining your weight and instead focusing on the things that you can, maybe your adherence to your medication or getting your blood pressure down, or changing your diet towards a healthier diet with more fruit and vegetables, but not necessarily reducing your calories. I try not to say to people, go and speak to your GP, but if you are one of those people with chronic conditions and you're thinking, I don't think I can necessarily do diet and exercise, but I do want to do something, do go and speak to your GP or your practice nurse about it when you can. Thank you very much for listening.
Thanks, Jen. Great timing and really interesting talk. So do keep the questions coming. We've got one more talk in this session before we get on to the discussion point, but keep asking your questions now so that they come through in time. You noticed there was a few questions that came through a little later after Asan's talk, so keep your questions coming while people are talking. That'd be great. So our next talk is from Ian Garner, and he's going to talk about resilience. What is it and can it be improved? Thanks, Ian.
Thank you very much. Is my Is this sharing? Let's see, let's try again. Can people see this?
Yeah, it's working fine.
Yeah.
Okay, fantastic. Okay, so as the title suggests, I'm going to be looking at resilience, a bit of a conceptual understanding as to what it is, how it links to frailty, and then what the benefits of that are. And then the big question is, what can we do about it to improve resilience? So the first question from the off is, when we say resilience, what do we actually mean? So we can define resilience as the ability to adapt to and or recover from a stressor. Now, even though we're going to focus on resilience in older adults, this is generally a lifelong process that fluctuates depending on factors that happen in your life. We talk about stresses as a general broad sense, but this can be something as an illness, bereavement, having a fall, anything in essence that significantly impacts on the individual. Now, when we talk about resilience, a good method to consider what this means is, if you apply pressure to a tennis ball, it initially changes the shape, or the stressor will impact on the tennis ball. But when that stressor is removed, the tennis ball reverts to its original shape. So in essence, if we apply this concept to a person, they are subjected to a stressor and that impacts on them. But once they are able to adapt to or overcome the stressor, they revert to hopefully, mostly, how they were prior to the stressor. And that's what we generally mean when we talk about resilience. The second point is, now we've heard a lot about frailty through some of these presentations earlier. And the question is, what do we mean by frailty? So another definition is that we describe frailty as a heightened state of vulnerability to adverse outcomes. The idea being that if you're frail, you're more susceptible to adverse events happening to you. So you're more likely to have a fall or be subjected to a stressor. And not only that, chances are it will take longer to recover from the stressor than if you compare it to somebody who's not frail. And the most important point, and this is what I'm going to focus on mostly at the moment, is that frailty is also characterized as a lack of resilience reserves. So when we look at these two components in relation to one another, that last definition is, or the characterization, is the implication behind that, is that we look at resilience and frailty as opposite ends of a spectrum. To be resilient is to not be frail, and vice versa. Now, there is some merit to this suggestion, as if we near to end of life and we can no longer adapt to a stressor, the capacity for, or say, to perform everyday functions, then we could arguably say that we lack resilience in this scenario. However, if we go back to our first definition of resilience, the ability to adapt to and or recover from a stressor. So if we look at these lovely tennis ball diagrams, and I am going to stick with this through here. So if we start applying this to frailty, a person becomes frail. There's two possibilities here. They become frail, which we will, for this scenario, say is their stressor, so the pressure has been applied. If they are able to adapt to the impacts of factors associated with that frailty progression, they can still maintain their everyday functioning. The implication behind that is that that you can be resilient and frail at the same time. Alternately, if a person is subjected to a stressor and have some degree of frailty, they can then potentially recover from that degree of frailty. Once again, we've seen interventions and discussions in earlier presentations about the benefits and how to combat frailty and things of the sort, so that they recover from the stressor and then they can carry on doing what they were doing prior to it. Now, the implications behind these again, first of all, from the top part where we talk about adapting to a stressor, which is a key component of resilience that is generally overlooked. The implication behind that, as I said, is you can be resilient and frail at the same time. Alternately, if you look underneath, where we talk about the recovery component, we can potentially link how well somebody recovers from a stressor to how resilient they are. For instance, if somebody was to have a fall, they could go two ways with that in essence. One, they can say, oh, I'm not the same person as I once was, and sort of accept that, or they can try to develop coping strategies to overcome the physical and psychological factors and issues associated with the fall to try and recover from the adverse impact and then continue to function as they were. But the implication behind all these factors and these different possibilities is that we shouldn't consider resilience and frailty as opposite ends of the same spectrum. If anything, we should say that they are interlinked in their progression, and that it's possible that as frailty progresses, an individual can lack resilience, but it's a matter of probability and not an inevitability. And a different definition for this, which I like to focus on, is one put forward by Costco, who says similar, but characterizes resilience in the context of frailty is that a frail individual who is resilient is able to function more effectively than an individual who is similarly frail but lacks resilience. And I think that's quite a nice characterization of how we can look at the relationship between these two factors. So we've done some research on this, and I'm just going to give you the quick highlights. So we wanted to look at the benefits of maintaining high levels of resilience when frail. And what we've seen so far is, in some of the research, people who are resilient when frail have reduced feelings of loneliness, increased perceptions of environmental age friendliness. What that means is resilient people perceive their environment to be better suited to their needs when frail than frail individuals who aren't resilient. Now, there's two possibilities to this. The idea is that this is just a perception, which may or may not be accurate. Ultimately, if people if their perception of their environments is accurate, then resilient individuals are better able to utilize what's available in their environment to still fulfill their everyday needs, as well as other physical, spiritual, and social needs as well. We've also found that individuals who are resilient when frail have reduced feelings of depression and anxiety symptomology and reduced feelings of exhaustion. So, in a nutshell, there is suitable cause to maintain resilience when frail, which brings us on to the big question: how do we build resilience? Now, the interesting thing with resilience is that it's very much contextual. So what helps in one environment or one context of stressor may not necessarily be as effective in another. But what we have found is that there are four recurring factors that repeatedly pop up across these contexts, which are social support, problem-solving skills, self-efficacy, and optimism. Now, the question is, how do all these four factors link? So here we have a nice diagram. We can see that optimism, self-efficacy, social support, and coping strategies all have their own impact on resilience, but also coping strategies seems to be the crux across them all as well. So each factor feeds into how well people are able to cope with problems, and that in essence can feed into an individual becoming more resilient. So what we took from this is that coping strategies is the main method to improve resilience. So if we improve an individual's capacity to effectively deal with problems, then that should theoretically feed into building resilience in that individual. And that was the procedure we took with this study. So we created a intervention designed to build coping strategies or improve coping skills, we should say, in participants, which was completed over 11 weeks. We gave participants a series of hypothetical scenarios and using mean ends problem solving, said here's the beginning of a scenario and here's the end of it, and it's your job to think of as many solutions as possible to get from A to B. And we also completed this task in groups, the idea behind this being that these individuals would meet new people, so hopefully build and increase their social network, so we feed back into the social support component. and also a social event, which could be, the idea is that participants spend time together, again, to build that connectivity between participants. And this went for 11 weeks, and again, participants completed one task per week. So there were 37 participants in total, 10 male, 27 female, aged 58 to 96. So there's quite a nice variation in the age range here, and they were recruited from 10 extra care retirement villages. We had 2 conditions within this group, an intervention condition or a delayed intervention condition, and participants were set using cluster randomized control trials to each condition. Now, I'll explain a bit more about that in a moment, but there were 3 assessment time points. So time 1, time 2, time 3. Now, between time 1 and time 2, participants in the intervention condition completed the intervention, and participants in the delayed intervention just carried on with their everyday lives. And then between time 2 and time 3, we reversed those roles. The idea behind this was that if we think this intervention is going to benefit people, then everybody should have access to it. And by doing the intervention this way, each condition essentially acts as the control for the other group between those time points. So the outcomes we assessed based on what we looked at before was frailty, problem-solving skills, anxiety, depression, loneliness, and perceptions of environmental age friendliness. Results, what we found overall from time 1 to time 3, we saw a significant improvement in problem-solving skills, which naturally links into coping strategies and coping skills, which is what we wanted in essence. Unfortunately, this did not feed into resilience, and we'll discuss why, or that may or may not have been a bit later on. But we also did see an improvement in anxiety symptomology. So these were the 2 factors that really came to the fore throughout this intervention. And if we look at each time point, so time 1 to time 2, and then time 2 to time 3, between time 1 and time 2, we saw the significant difference between these 2 conditions. So, and then time 2 to time 3, we didn't see anything. Similar with anxiety. On the surface of it, what we would like this to have meant is that at the time 1, there was no significant difference between problem-solving scores and anxiety, but then there was between time 2 because we saw an improvement in the first intervention condition. But then at time 3, that the difference vanished because we then saw an improvement in the delayed intervention condition to feed up to it. Unfortunately, it was not that positive. So on the left here, we've got our mean end problem solving, which was our assessment of problem solving skills, which feed into coping skills. Now, we did see an increase in our average MEP score, so how many solutions participants provided from time 1 to time 2, but that unfortunately decreased from time 2 to time 3. Similarly, we saw improvements in one condition in anxiety symptomology that were not retained. We saw a decrease from time 2 to time 3. Now, the question is, why did this happen? So we're going to quickly go in because I'm not sure of the time. So in short, we found that the intervention was effective in improving problem-solving skills, but those improvements weren't maintained. So possible reasons for this is that after participants completed the intervention, they reverted to their everyday life patterns. So perhaps if we want to see this maintenance in benefits, we actually need to see a change in behavior as opposed to a short intervention. So maybe somehow we can keep participants just completing problems more frequently in their everyday lives, as opposed to a one-off, well, say 11-week program. Now, the other point is, why didn't we see this improvement feed into resilience, which is kind of what we were really hoping for. And one theory that was put forward, which I'm quite optimistic about, is that we will not see this improvement in resilience unless older adults are subjected to a stressor. The idea being that you can't build resilience towards something until you have been subjected to it in the first place. unfortunately, we can't, ethically speaking, push older adults older and then see how well they recover from completing this intervention. So we just have to, hopefully in the future, we can do some more long-term research and then see how participants are able to recover from stresses, and then we would be able to better gauge if the intervention was effective in terms of building resilience or not, or at the very least preparing people for issues in the future, and then hopefully they can recover a bit more effectively from them. And that's the end of the presentation. Thank you very much.
Okay, thanks Ian. So now we have a short time for questions, and I think Anthony's going to just try and put people's faces back up if he can. So we've got a few questions here. I'll just start by reading some of the questions out. So we've got a question, first of all, from Sangeetha for, let me just find it. Yeah, so this was for Christine's talk. And Sangeetha said that for a long time, the ageing discourse was about frailty, impairments and coping, and suggests that the older people looking to engage in outdoor adventure activities is a move towards more positive ageing, and it's an interesting trend. So her question is, do people with certain personality type go for these kind of activities more so than others? So I don't know if Christine, you've got any thoughts on that?
Yeah, can you hear me, Carol?
Yes, I can, yes.
Great, okay. Thanks, and thanks, Sangeetha. That's an interesting question, and I think it's fair to say that the earlier literature, maybe going back about 20 years ago, was actually quite negative on the sort of personality traits, describing these sorts of people as having sensation-seeking personality disorders, which I think is quite a negative way of thinking about that. So, but I think more recently, this kind of characterization's changed quite a lot. And in part, that's because many of the nature adventure sports that people are becoming involved in have become much more mainstream. So we see them as part of major sporting events and so on, and therefore we don't see mountaineering, for example, or mountain biking and so on as being something that's a bit out there so much, and they've become much more popular. And on top of that, there's also been a growth in a very profitable industry that's surrounded these kinds of sports. I mean, you won't see a mountain biker out nowadays without, you know, the full gear and kit and everything, and the bikes that they have to buy. So all of this is a way of saying that these sorts of activities have become much more mainstream, and so the thinking about those people as being somehow a bit out there has changed. Plus, I think there's been increased recognition of the health benefits. So I think we're thinking much more positively about the sort of personality characteristics that people have. But thinking about the people themselves that we were talking to, they described things about having characteristics of stoicism and stubbornness, single-mindedness. Some of them talked about having Peter Pan personalities. But in essence, some of this goes back to some of the things that I think Ian was talking about, in that they definitely displayed coping and resilience aspects to their personalities. But I think it's much more than just a personality issue. So it's, how did they come to be involved in the first place? What is it about their engagement with nature, their introduction to nature? So I think it's, whether it's about the socialization through family, through community, neighbours, friends or whatever. So I think we're saying that, yes, I think there are some aspects of personality that we have to account for, but actually it's much broader than that. And I think just to see it as a single personality trait actually is quite a narrow way of looking at it.
Okay, thanks. I think there's a lot to it, isn't there, Christine? So we've got another question here from Jill, and Theo's put a website that might be useful in the chat that you can all see. But Jill said that there seems to be a kind of grief when your health deteriorates, and you can't do what you used to, but still know it's important to do physical exercise and knowing how much to push yourself and so on. And it seems quite hard to get advice about this. And Theo's put some information in the chat, but I wondered if you wanted to respond, Theo, or maybe Jen as well.
Jen, do you want to go for, ladies first, or do you want to start and then you can jump in given your situation?
You start because we can see you.
Okay, fair enough. So yes, the NHS has some advice in terms of physical activity. It also has some advice in terms of activities people can do to improve their balance and avoid falls. However, I'm not sure if the question relates to something a little bit more specific. The advice is obviously quite generic. Jen already talked to us about personalizing a particular program, if you like. So I don't know whether the question meant that we need something more specific to that. And if that's the case, I would be more than happy to take people's questions, or if they can email me about something more specific. But the website does a good job in terms of linking activities to intensity. So it gives you examples of vigorous activity, it gives you examples of moderate activity. So it links the activities to the intensity. So effectively, an easy way is to pick an activity from the higher intensity band, if that makes sense. And that will make you push yourself a little bit more. To go back to what I was saying earlier and close the answer, Carol, we have evidence actually to suggest that when people do activities they enjoy, they work harder, and importantly, they work very close to the thresholds we would want them to have physical benefits, to have fitness benefits. So yes, that's me. I hope it answers the question.
Yeah. I have to say as well, I think we've probably tried and probably failed to an extent to move away from this idea of physical activity being something that could be dangerous, so that we should be scared of. Decades ago, when people had heart attacks, they were told to rest, for example, and nowadays we put them through actually physical activity programs and actually encourage people to get active. Same with respiratory disease, other conditions. And then it's quite difficult if you join a private gym and you have conditions, they expect you to go and see a GP, then the GPs get all grumpy about having to sign off on these things. Really, actually listen to your body, and as long as you're not pushing yourself, or you don't have a very specific condition, for example, with joints or something that's going to cause you actual harm, then you're probably going to be okay. If you feel you want the confidence and the reassurance, then actually a lot of the programs that are run in the council gym, and this is the problem just now, is accessing such things, are specifically designed for people with a range of different health problems, and they will give you a gradated and program to follow to help you build up to that higher amounts of physical activity. But it's not something to be scared of, and I know exactly why people probably are, because I think that's been our problem perhaps as a medical profession, perhaps bringing that in in the past.
Thanks. So we've got another question on resilience here from Diane, who said she's very interested in the concept of resilience, and thanked Ian for highlighting it, and asked the question whether COVID could have an adverse impact on resilience for many people through the enforced social isolation. What do you think, Ian?
I think most likely, yes. COVID and lockdown was very new to us all. Interestingly enough, we're currently doing a study at the moment that was looking at many of these aspects of COVID during lockdown, and social isolation came into it as well. Now, just focusing on older adults for this particular point, what we've found is through some of the initial analysis is that older adults who are frailer are not feeling as impacted as much in terms of how lockdowns affected them compared to some of the older adults who are more robust. Carol can probably jump in on some of this as well, since she's been pretty involved too. But usually you would see this very big difference in terms of, say, quality of life and functional capabilities, what people can and can't do between robust and frail individuals. But that has been vanishing through lockdown. not necessarily because people are becoming more frailer as a result of lockdown, but because they're so restricted in terms of what they can actually do, that it's almost as if they're living the life of a frail person. And what we have seen is one of the particular questions is how much has the situation affected your life generally. A lot of the frailer older adults are saying, oh, it's not affected us very much, but a lot of the more robust older adults are saying, you see, it's a lot worse in terms of their everyday life and how it's affected them. So it's bringing it all back to resilience. If for the frailer older adults, I would say it's probably not affected as much because they're very limited anyway in most aspects. So if they couldn't go out before COVID through physical capabilities, then they can't go out anyway now. So their resilience and capacity to manage won't be as challenged as much as somebody who was used to going out more often, as a specific example.
Thanks. Yeah, thanks, Ian. I think it's, you know, some really interesting results coming out of that study. Sandra and I are going to talk a little bit about that study this afternoon, but not necessarily about the resilience. I think that's a good point to get over. I'm just double checking if there's any other questions that I've missed. I think Asan, there were some questions that came in a little later for Asan, and I think Asan has answered quite a lot of them in the chat. But I think one of the main issues was that somebody suggested that depression and isolation and mental health problems didn't really come up on your list of things that people talked about. I don't know if you want to comment on why do you think people didn't think we should be doing research on those kind of issues in the study that you talked about, Asan?
It did come up, but it wasn't sort of on their top 5 list. But there was the things about isolation and psychological well-being and things like that. I think with what has happened more recently, I think it's brought to the fore anyway, if people were not aware how important that can be. Yeah.
Okay, I'll just do one final check for new questions, and but keep them coming, because we can always go back to people throughout the day if you think of a question. So what we're going to do now is we're going to end this meeting, and then if you would like to join, so let me just see if I can get the lunchtime events on the screen again. Let me just find that, so if I can just share the lunchtime events. So just to remind you that we're leaving this meeting now, and if you can now go and have your lunch, and you can join any of these events. So we've got the poster presentations, and we've also got the other parts of the exhibition. So have a virtual wander around, meet some more researchers, meet some of our PhD students, find out how you could get involved or how you could learn a little bit more, and then we'll come back at 1 o'clock. So if you start joining the afternoon session at about 5 to 1, that would be great. And that's a new Teams event to click. So on the programme you've been sent, where it says join the afternoon session, just click on there and that'll take you to the afternoon session. Okay, enjoy your lunchtime.